Next in our program is the topic COVID-19 and children's mental health. Lessons learned from the Red Cross Mobile Health and Wellness Project, which is going to be presented by Ms. Carolina Ferreira, Deputy Director and Child Protection and Sexual Education Program Manager for the Cayman Islands Red Cross. Ms. Carolina.
Hi, good morning, everyone. So thank you so much for the opportunity for us to be able to share a little bit about our Mobile Health and Wellness Project. It began last summer, and part 2 of the project is actually ongoing. So I'm just going to tell you a story, and I'm going to start more or less at the beginning, and it feels like both 100 years ago and just yesterday, right? So as you may remember, COVID-19 officially reached our shores in March of 2020. And the timeline between the confirmation of the first case, the first COVID-attributed death, the closing of schools, and the subsequent lockdown measures all happened within a fairly short time span. Schools were closed on March 16th, originally for a period of a month, but it became pretty clear early on that there was no way that schools were going to reopen in April. And you'll remember that for us as a population, it took us a minute to fully grasp the gravity of the situation, and it wasn't until after the 48-hour lockdown that really and truly the movement restriction measures started to work. So the Red Cross functions both in times of peace and in times of disasters. And as a disaster response agency, we know that emergencies disproportionately impact the most vulnerable. COVID-19 was and continues to be no different. What was different about COVID-19 was the fact that it helped the suppression measures that we were using to stop the spread of the virus was also creating brand new and exacerbating existing vulnerabilities due to things like the closure of the schools, shelter-in-place directives, and isolation measures. So in a safeguarding perspective, obviously this starts to raise red flags, and this is when we start taking stock more or less of what is happening. So we started by trying to figure out what we knew. And what we knew was that the reports of child abuse decreased, mostly due to the closure of schools, but that in general, child abuse and domestic violence always increase in emergencies. We knew that not all children had equal access to online learning and that some of them were not logging in regularly to sessions. And we also knew that the shelter-in-place and curfew measures had impacted children's mental health and that the ongoing messages about COVID had increased anxiety in children as well as adults. What we didn't know was the extent to which abuse was taking place, the extent to which COVID was impacting children and adolescents' mental health, their ability to learn, and their physical health, and whether or not children had thoughts, fears, and concerns about returning to school in September. And so it was out of both of these things that we knew and that we wanted to find out that the idea for the Mobile Health and Wellness Project came to be. It was really simple. Basically, we were outfitting 2 of the Red Cross vehicles as these mobile units that would get into the communities to be able to provide some of our most vulnerable residents with a health and a mental health and a physical health check. This was done under the umbrella of the Protection Starts Here project with funding from hedge funds. And as you see there, even though we cast a wide net asking for assistance from service providers, the one who came to the table and who stuck with us were HSA, EAP, Encourse Cayman, the Wellness Center, the Children's Clinic, Aspire, and the Family Resource Center. So what we ended up doing for a period of 5 weeks in July was to provide this physical and this mental health check. The physical health check was really the carrot that we dangled to parents because we know that parents would want to make sure that their kids' physical well-being was there. The school screening tool was what we used as a way to both standardize sort of what the service that was being provided, but also as a way to assist because we know how slammed HSA was with all the COVID response, and the school screening tool is a very important component for kids in certain age groups going back to school or going into school. The doctor and nurse on site were also providing the health, height, and weight measurements, as well as asking children questions about their well-being. Now, as part of the service, we had also attached the mental health checks, which Dr. Lamb was speaking about, the ARCADS, the DSM-5, and the parental stress scale. We have a lot of data that we're still going through with this, and as soon as it's ready, we're going to make sure that we share it. And the idea behind the parental stress scale in particular was the recognition by our mental health providers that you cannot speak about the mental health and well-being of children without addressing how their parents and caregivers are doing. So the aims of the project were basically to provide the families with both these physical and mental health checks for the children and adolescents, and to also begin to gather some data that would help shape the way in which we informed school-based interventions and other community approaches. By the time it was all said and done, we served 178 children, spending over 150 hours in the community. We had the support of 33 health professionals and 51 support volunteers and 13 partners, and we did this over the course of 5 weeks in 21 different locations in Grand Cayman. The first set of findings, it was that of the 178 children that we served through this project, we had 99 physical health referrals. These had a lot to do with vision, hearing, nutrition, some people who just needed regular checkups. We had 118 mental health referrals and 43 referrals for parental support. Now, even before we started this, we knew that given where we were at, that the free services for mental health provided through the Department of Counseling Services was already overstretched due to the pandemic. We also knew that people had a lot of access issues when it came to either losing the insurance or not necessarily being aware of what their insurance coverage would be for mental health services. So the mental health providers for the project had already started talking about, okay, well, we go into the community, we figure this out, and then what? What do we do if people really need our help, but it's going to take them 2 or 3 months to be able to access services? And so we put sort of a contingency in place that we were then able to act on, which became part 2 of the project, which was basically a short-term mental health services that were provided to persons who were identified through part 1 of the project as being highly vulnerable. And this was in 8 session packages that were created by our mental health partners. And we were able to secure funding from ART3 to cover 18 packages, which was also in line with what the capacity of our private sector providers would be. And one of the things that we also ended up including as part of this second part of the project was transportation assistance, because this was something that was identified by school counselors as being a potential barrier to access to services. So ensuring that some of our most vulnerable families could get to and from appointments was also, something that we wanted to ensure we were setting people up for success. So the findings to date, and this is still the part that's going, we have assisted 5 families, which represent a total of 16 individuals for services. And some of the main issues that have been identified, as you will see, is in line with what Dr. Lamb was presenting, with suicidal ideation in children, dealing with grief and loss and parental incarceration, anxiety, depression, attachment issues, parental rejection, a couple of cases of brutal physical attacks, and a histories of child sexual abuse, all of which ended up being exacerbated by the COVID-19, the lockdown measures. So the key lessons learned to date when it comes to this, first and foremost, was the need for more district-level access when it came to services for children and mental health services. It really made a difference for us to be in the community as opposed to asking people to come and meet us in town. So being out there was really something that the community appreciated. The second part was health insurance coverage was an issue even before COVID-19, and you could see that there was a significant number of people who either had inadequate or did not have health insurance coverage for themselves and their children. A lot of people did not have a primary care doctor that we could identify to say, even send the files that we had to that doctor so that they could see the assessments that were done. And even though we were in the community and we advertised and we worked with partners on the ground, we know that there's a high number of highly vulnerable individuals who did not access the service. And this is something that, again, going back to this idea of district-level access, we need to build rapport and have some consistency in order to be able to provide this service more meaningfully to the most vulnerable in our communities. The cultural stigma over mental health support still remains. We saw that when the parents were there with our mental health providers, they seemed to be, very engaged and very supportive. But then once they left and we were following up on seeing how they were doing and with the referrals, it became something, oh no, we don't really need that, everything is fine. So it's about kind of creating that link where there is that ongoing support. And perhaps, one of the things that was most glaring to us was that one of the key issues that some of our most vulnerable families who accessed Part 2 of the project had was they had trouble accessing services even when we covered costs and we provided transportation, and that was basically due to a lack of personal capacity to access services. So when we're talking about personal capacity, we're talking about issues surrounding childcare. So for the caregiver who's, a single-person household or single adult household that's taking care of multiple children, and they have been referred to family counseling, and family counseling starts with the caregiver, but they don't have anyone to leave the kids with to be able to go and access the service. Reliably meeting basic needs. So even for persons who were under NAU coverage, it's still feeling as if they are in limbo due to things that are happening as far as delays and other things, and not having the mental space to be able to access services and take care of themselves when they're worrying about the rent being due and having food on the table and all of those things. The ability to schedule, keep, change, and cancel appointments, as well as the ability to clearly communicate their needs and feelings and to ask for additional help and support. So again, these are all things in which if people are already maxed out, having to deal with it, then, it's just like it becomes difficult for them to meaningfully engage and access these services. So the 3 recommendations that we have, and I appreciate that I spoke really quickly, so I apologize for that. But basically, there is still a need for a holistic approach, not only amongst government agencies, but also as they interact with NGOs, private sectors, and the community to support the most vulnerable amongst us. That we need to look at people much more holistically than we do now. And as part of that, we need to set up a proper referral and accountability mechanism, which will allow us to better understand where the referrals go, who has acted on it, who has not, because right now it's sort of a bit of a ping pong that ends up happening. And possibly most importantly, we need to set up both client and or patient advocates that can actually help people navigate the system. And they can actually help service providers set realistic goals or manage their own expectations as to what it is that clients and beneficiaries are able to do. Because again, if we're going to this issue of personal capacity, if individual service providers are only looking at a part of the issue and we're making a recommendation that appears to be very small, but not taking into account everything else that that person or family has on their plate, then we're not addressing the personal capacity issue that we have. And last but not least, an advocate would assist these individuals with empowerment so that they can begin to find their own voices and advocate for themselves. So that is it from me. Thank you for your attention. And if anyone has questions or wants to speak to me afterwards, I will be around. Thank you.